the scarring triangle is a concept that revealed itself through our difficulty in threading a catheter from the sacral hiatus to the straight to the ventral aspect of the L5 nerve root. L5 S1 is commonly involved in degenerative, post-traumatic, post-surgical scar formation. And the catheter just would not go. You cannot force a bigger catheter because when the nerve root is scarred down, you're forcing yourself with a stiffer device. It's neuropraxia. You got blunt injury to the nerve. You may end up with a worse pain than you had before. Teske came up with recognition, and his group published in European Spine Journal that underneath the armpit of L5 and lateral to the S1, there is this uniform space, averaging left and right 1.1 ml, then they came up with 0.9 ml in a conclusion. And they also realized that if they place a needle to this scarring triangle, I named it later, because we recognize that this space, not only 0.9 to 1 ml, but it is a space that collects all the waste material and it forms dense, hard scar tissue that leads to failed minimally invasive surgery that focuses on the lateral recess, fails fusions, fails attempts to place a catheter below because it's so hard, and the curvature of the sacrum channels anything coming from the sacral canal into the posterior epidural space. And you curve down above L5 only above the scarred down nerve root. Epiduroscopy fails because the scope goes above and then curves down above. Fusion fails because the problem is above the disc and more medial than the lateral recess. I am showing now a typical case. The patient has severe left-sided foot drop, low back pain, numbness involving the L5 outer calf, pain down to the little toe side, S1 distribution, numbness of the toes. To a lesser extent, the same kind of things happening on the right side. He goes to a highly reputable place because this unique space has not been recognized by the surgical literature as a scarring triangle. So he has minimally invasive surgery, no change in the pain. So they go in and look, and all they find is dense scarring. So they close, and the case pretty well stopped for the next 3 years, other than progressive weakness and progressive numbness. And even though there's extensive workup, the solution for scarring has not been arrived at in the surgical arena, because if you operate for scarring, you end up with more scarring. Same time, he has an asymptomatic cervical spinal stenosis, so he has fairly extensive neck surgery, even though had no complaints. It was an incidental finding, so it was a prophylactic neck surgery. Same time, a few years ago from Korea, there's a series of comparative study, prospective evaluation of severe and moderately severe cervical spinal stenosis, and cervical lysis is followed by excellent outcome, both in the severe and the not severe, moderate to severe cervical spinal stenosis. Since then, we have found, based on the work of Berkemeyer, who did a human cell culture evaluation of the various substances used during the neuroplasty procedure, comparing local anesthetic, hyaluronidase, and different concentration of sodium chloride, 2, 4, 6, 10%, and triamcinolone. And he found that the local anesthetic does not interfere with fibrocyte regeneration. Hyaluronidase does not interfere with fibrocyte regeneration. The hypertonic saline does interfere depending on time and concentration exposure. So the higher the concentration, the more interference there is with fibroblast regeneration. Triamcinolone, interestingly, also interferes with fibrocyte regeneration. Recently, two publications regarding hyaluronidase showing in one group that hyaluronidase pre-treatment with the bovine testicular extract has inhibited the irritant's attraction to neutrophil invasion. Another similar study, virtually identical, Hylenex, which is a human recombinant hyaluronidase, did exactly the same. So that neutrophil invasion was reduced, which means that the inflammatory changes that come following the neutrophil invasion are prevented when hyaluronidase is used. So hyaluronidase is hugely important in the lysis procedure because it facilitates finding the path of least resistance, and the actual procedure is that of compartmental filling and a fluid finding the path of least resistance. Contrast is viscous, hyperosmolar, itself leads to expansion of the volume over a period of time following the procedure. Hyaluronidase does not lead to expansion, does not lead to inflammation. It inhibits the consequences of neutrophil infiltration. Now, the patient that you will be seeing now is a gentleman who had the minimal invasive surgery, had the follow-up surgery, finding scar tissue was closed. Then they do a cervical significant procedure. He didn't have complaints before, neither does he have complaints since. 3 years later, he comes with a foot drop, numbness, and a reproducible back pain from movement of the dura when I had him bend forward and move the neck, pull on the dura, a dural tug, and he reproduces the severe pain to the left side right there. We do a trans S1 placement of a Versacath. Now, why a Versacath? Because Tomikichi Matsumoto from Japan, for whatever reason, he went through trans S1 to get down to the ventral epidural space, avoid the curvature of the sacrum, and through the 18 gauge needle, following placement of an obturator, second stylet that projects 1 millimeter beyond the tip, so that when you rotate the curved needle, so the curved needle can thread cephalad, and not laterally, but above the disc, and not above the takeoff of the L5 nerve root. It's about a third of the way up above the disc line. And once we are there, injection of contrast, which is tremendously difficult, hard injection, and inject 10 cc's of contrast. Following that, we inject 10 cc's of hyaluronidase, and that 10 cc's of 0.2% ropivacaine and 40 milligram triamcinolone. Now, these are the substances that have been evaluated by Berkemeyer and published in Pain Physician. Amazingly, beforehand, the patient on dural tug points to where the pain was. He cannot bend forward about a foot, probably a foot, maybe more away from touching his toes. And immediately post-procedure, he can bend down, the dural tug pain disappears, and he can touch his toes. And by the end of the first day, the foot drop disappears. He's able to walk on tippy toes as he sends me a videotape picture of the recovery of the foot drop. He sends a very nice letter that thank you for allowing me to walk normal again. Now, 12 months follow-up, I shall report on that, but I expect him to have recovered. Our usual approach is to do a trans-S1 with a Versacath and inject the 10-10-10, and then where the dye spread on the lateral ventral epidural space ceases, then we come in transforaminally on the first visit with a blunt needle. And you have to be careful because there's a beautiful demonstration here that there can be a venous runoff at that point, but just redirecting and allowing the venous drainage to take place, the venous runoff stops. But you need to be careful that you not to inject a cardiotoxic medication into a vein directly, because you can have, even with 0.2% ropivacaine, although less likely, than bupivacaine or a higher concentration of local anesthetic. Like lidocaine could cause seizures, so it's medicine. You have to be aware of what you are doing and what the consequences are. And this is a beautiful example coming up to evaluate the potential consequences. Now, interestingly, this model here nicely shows that even though you think you're going at a bit of an angle, but because the sacrum tilts that way, it may still be not getting into the S1 neural foramen. So you may have to curve a little bit more, almost vertical, but it still looks like, when you look under the C-arm, it's going to be coming like it's at an angle. The interesting aspects of the normal anatomy are that the dorsal or posterior S1 is higher than the ventral S1 because the nerve is going down at an angle. We usually start out at S2, but you may have to be a little bit lower, because when you look in the lateral view, you need to be a little bit coded, little bit below the S1 neural foramen that goes through the sacrum. So if, when you look on the lateral view, you are at or above the S1 neural foramen, you need to come a bit lower. And this is something that we are relearning. And you would think that by now we figured out. But I probably spent like 8-10 minutes in trying to get in, and eventually had to come to the natural, and realizing that I was higher than the S1 neural foramen. There was no chance of ever getting in, so I had to eat a bit of dirt and re-establish the entry point a little bit lower so that I could get on the lateral view just below the S1 neural foramen, and it goes through the sacrum. So that's a very important landmark. Furthermore, if you use a straight needle, the catheter will run into the S1 bony structures and obstruction. That's why using the 18-gauge RX 2 coude, when I rotate with the second stylet, it allows me to go up cephalad. And then we go to the lower end of medial to the L5 nerve root. You cannot be below the disc. The scarring triangle is above the disc. That's the explanation for the surgical failures, for the endoscopic failures, and for the catheter failures. The huge big lesson we learned, secondary to the observation of Matsumoto, that a regular sized catheter does not go into the space between the dura and the posterior longitudinal ligament because of this dense scar formation. But the VersaCath, which is a little bit smaller catheter, can go into the scar tissue. And it is the fluid that does the work by the compartment of filling principle. 3 years he had severe debility, pain, and we've been able to reverse these. Now, I have a virtually identical story. The patient has a little spondylosis at L5S1 and almost crippled with pain. We did trans S1 and a transforaminal injection with a blunt needle, the S1 with the VersaCath, and got a couple of months of great pain relief. The pain was coming back. So then we came with a trans S1 and a transforaminal catheter to mid-canal. The transforaminal catheter is because we need to administer the 10% sodium chloride. And for the trans S1 area, the L5S1, we go with 10 cc, same as the local anesthetic, 10% sodium chloride, and the transforaminal mid-canal, 5 cc local steroid, and 5 cc of hypertonic. And you flush it, and we repeat the hypertonic 3 times. Why? Because the increasing time and increasing concentration inhibits fibroblasts. And now we see follow-up in the Techniques of Neurolysis book. You'll see the last time I did the L2-3 transforaminal was in 2002, so that's 14 years follow-up on the man that introduced epidural steroid by working with Alan Winnie to do the first steroid that was subsequently published in a series in Anesthesia Analgesia in 1972, as Winnie, Hartman, and there are like 5 authors involved in that particular study, which, by the way, has 0 references. That was the first time, even though supposedly the information came from French colleagues of spine surgeons. The steroid idea has spread, but the most relevant aspect of the steroid story is that now it's gradually being conclusively proven that if you do not go through the neural foramen, there is no serious long-term positive outcome. In order to have positive, serious long-term outcome, you have to be going through the foramen of the affected radiculopathy. Additionally, we have learned that when you do a fluid foraminotomy by injecting under pressure, you virtually abolish the hazard of hematoma, because once you open up runoff, the veins collapse under pressure rather than the fluid dissects into them. And now, hope you enjoy watching this video sequence.